So, Betty Cherotin, Diana Cherotin, you are the one? Okay. Joshua, again, I have not seen Joshua, but I'm told Damal will stand in. Damal, are you in the house? Please mobilize all this fire I'm calling so that we can start when we have our house in order. And then Louis Ochen. Who is Louis Ochen? Oh, good. Okay. So before we start, we are going to put some house orders. The presenters will be given strictly 8 minutes for their presentations. And we are going to first make 4 presentations. We have a discussion of 10 minutes. And after those, we will go into another group of presentations, which will last 20 minutes. And we hope that we will be done with our session within 1.5 hours from now. That means it will take us to exactly 4 p.m. So ladies and gentlemen, allow me to invite the first presenter, who is Madam Mabel Nakawoya. She's going to be presenting about strengthening TB care through digitalization and the national scale-up of the electronic case-based tracker. So, Madam Nakawoya, you're most welcome. 8 minutes, and we will be alerting you when there is 1 minute remaining. Thank you.
Okay. Good afternoon, everyone. My name is Mabel Nakawoya from the National TB and Leprosy Program, Ministry of Health, and I'm here to present strengthening TB care through digitalization, a national scale-up of the electronic TB tracker. Okay. So in the past, the Uganda TB program has relied on aggregate data, which is really limited. It's not detailed to give you different details about the patient so that we can do TB surveillance. So because of this, the program developed an electronic case-based surveillance system, which is an electronic TB tracker based on DHIS2. And this was developed to mainly improve the TB surveillance, to be able to get real-time individual level data, to track the patient through the continuum of care, and then also improve reporting and timeliness. We started in 2020, which was a development phase, and in 2021, We did a pilot which took on 35% of the DTUs, and by 2025, this year, we've been able to enroll 72% of the DTUs, and this has been possible due to clustering trainings and integrating with the available HIV platforms. We have 88% of the TB patients in the system so far, and for MDR, we've entered all the patients, and the key success factors have been engaging the district leadership, being able to do continuous mentorship, and leveraging on the available platforms like the EMR, where we had the computers, and therefore a facility that didn't have computers in the TB clinic was able to use the computer in the HIV clinic to use the system. In conclusion, the system has, the TB program has been able to demonstrate transitioning from paper-based to electronic case-based surveillance system, and this has been possible and it's feasible. Therefore, we encourage all the different departments to carry on this. The key lessons learned: engagement of the leadership right from the top to the facilities, being able to do data use so that the facilities are able to enter data and use it. When they're able to see the use of the data they are entering, they are encouraged and motivated to use the system. And then also, in terms of reducing costs, we've been able to leverage on the available platforms like the EMR computers to be able to reduce costs. Some of the challenges we've suffered, we've had 88% of the data in the system, but 12% of the data is not in the system, largely because of human resource, internet connectivity, and timeliness. And internet connectivity, and for the facilities that don't have computers. We've not done this alone. We've done this together with the IT in Ministry of Health, the DHI program, the funding agencies, CDC and USAID, DOD, and all the rest, and then the implementing teams, which move from the regional level, district level, and the health facilities. Thank you so much.
Thank you so much, Mabel. You can take your seat, back your seat. You've done so well in a way of time, because you've saved us some time, some 4 minutes on the clock. So let me right away call upon the next presenter, who is none other than Ignatius Senteza. Is presenting on maximizing impact with limited resources. I think this is something of interest. Not everything is of interest, but limited resources. Using the GIS guided TB screening in Kampala, Mukono, and Wakiso district. So, Dr. Senteza, you're not here when you are setting the house rules. It's 8 minutes, and we don't go beyond that. The only thing you can do is less than 8 minutes. Thank you.
Thank you so much. Good afternoon, everyone. Yeah, so I'm going to present to you our work in line with maximizing impact with limited resources, and I'll focus on GIS-guided screening in Kampala, Mukono, and Wakiso districts. Next slide. Okay, so as the next slide is coming on, Dr. Ignatius Senteza, and I'm the Senior Technical Advisor for the LPHS TB activity. Recently, it has been renamed to Urban and LPHS TB activity. So in Uganda, we continue to miss an estimated 10% of the TB cases. And this is likely to get worse, especially in line with the reducing funding. And this is likely to worsen the TB case detection gap. So this calls for urgent innovations and efficient use of the few resources that we have. And as a OPHS TB activity, we used geospatial data to guide our community TB case finding activities. And I'll be sharing with you what we found after. So in 2024, our project began capturing GIS coordinates for each and every patient who is diagnosed bacteriologically. And we thought by capturing the coordinates of those patients who are PBCs, we are likely to identify the areas where these patients have either infected someone or where they were infected from. So this was done during contact tracing activities, and we used Kobo Collect, which we installed on the phones of the community health workers to have these GIS coordinates collected. So after getting these GIS coordinates, we constructed heat maps using GIS software to help us identify TB hotspots and cold spots. And we compare, and in this presentation, we shall be comparing the yield, the TB yield from GIS guided screening versus that from non-GIS guided screening for that period. So this slide is just showing us, when we use Kobo Collect, the first graph, the first picture is showing us the raw data, how it comes through. And the second one is showing us an output after using the GIS guided software to construct the maps. And this is specifically for Kampala. And if you look at it clearly, you can see clusters of tuberculosis in the different localities within the city. So our results, overall for that period, we have about 200,000, more than 200,000 patients who were screened. And of these, 43% of them were screened specifically from GIS-guided hotspots, and 57% came from the mass community screening. What is interesting is the presumption from both approaches is almost similar, with 20.4% from GIS-guided screening and 21.8% from the mass community screening. Mass community screening here we are referring to, we mean community health workers move out to do screening without necessarily using the data available from what we have. So despite the fact that the presumption rate was almost similar, we see that the absolute number of cases that were diagnosed from GIS-guided screening is 952 versus the 730. But also if you look at the numbers we screened under GIS screening, the numbers are fewer, but the cases are actually more. So in terms of proportions, we are seeing a 0.7% yield among those screened from GIS-guided versus the 0.6%. And we are seeing a yield of 4.7% TB yield versus the 2.5% from the community screening. To share more on these results, you see that if I'm to summarize these results, are focusing on what is the yield per 100,000. You can see that the yield from GIS-guided screening per 100,000 is 9.7, and it's 5.7 per 100,000 when it comes to mass community screening. But also, if you look at the number of individuals needed to diagnose one TB patient, you need about 104 patients with GIS-guided screening, and you have to look for about 177 patients to diagnose a single TB patient from mass community screening. And lastly, when you look at the presumptives, you need about 22 presumptives to diagnose a TB patient from GIS screening, but you need about 39 patients, almost twice, from mass community screening who are presumptives. So in conclusion, we are saying that GIS-guided hotspot screening, it has proved to be more effective and efficient than untargeted mass screening, and that TB programs should prioritize GIS-driven hotspot identification to maximize case detection and optimize resources. So this is the last slide, implications. To begin with, we can see that ever since we introduced GIS-guided screening, we have been able to register a high proportion of patients who are diagnosed bacteriologically, while at the same time improving and sustaining our TB case finding detection. And we are also saying that this is something that is doable based on the fact that picking these coordinates is very simple, and it can be integrated in the routine community activities irrespective of what disease is being targeted. And we just need a smartphone to do that, and the community health workers can do it effectively. Thank you so much. We acknowledge those on the screen.
Thank you so much. Please come up on the podium and sit up there. But also thank you so much for keeping time. We have listened to screening approaches using the GIS, and now again we want to step up the gear into another screening presentation, none other than Louis Ochen, card for TB, precision play, threshold 45 optimizes TB screening in West Nairobi's high burden setting in Uganda. So, Chen, you are most welcome to make your presentation. You know the rules very well, so thank you.
Thank you very much. All protocol observed. Good afternoon. I am Louis Ochen from Uganda Catholic Medical Bureau, and today I share with us findings from digital X-ray screening in West Nile, where we will observe what the outputs were and what our findings were in the period of 2020 to 2024. Now, we know that Uganda adopted artificial intelligence for TB screening, where we are using computer-aided diagnosis for TB, the software, for interpreting the scores, which move from 0 to 100. And nationally, a score of 50% and above is taken to be presumptive, which necessitates picking up a sample for evaluation using majorly GeneXpert. Now, while this threshold helps to balance sensitivity and specificity, we also note that, like in West Nile and like in other places, where there is high burden, there is need to adjust the thresholds in order to improve the case finding. Also in 2024, September, during the CAST TB Plus campaign, a threshold of 30% was piloted in West Nile using the 2 digital mobile X-rays in order to try to maximize case finding. But we noted that it resulted to substantially higher referral rates for GeneXpert testing. So our main objective was to observe over the 4 years what is the optimal score for CAD for TB looking against the standards of 50% and also the 30% which was piloted during the CAST Plus campaign. In a retrospective cross-sectional study, we extracted data for the person screened with digital X-ray between 2021 to 2024, picking 6,000 records. 188 were TB positive, confirmed with GeneXpert, and then we see about 4,600 were negative. About 1,100 patient records lacked a gene expert result and they were dropped from the analysis. Receiver operating characteristic analysis assessed the diagnostic performance, and here we looked at specificity, sensitivity at the different scores, but we also tried to see the referral burdens and then the number needed to test and the positivity yield across the various scores, starting from 0 to 100. What were our findings? The results show us that CAD for TB software is actually very excellent in TB screening in the country, just like it is reported in other studies, with an area under the curve of 0.97. Looking at threshold of 45, we achieved a 96.81% of sensitivity and then a 94.2 specificity. And out of the 188, threshold 45 detected 182 TB patients. And we needed to refer 453 people for the screening. Number needed to test is 2 and a yield of 40. Threshold of 50 gave us yielded sensitivity of 96.2 and specificity of 98.02, and then it identified one less TB patient compared to threshold 45. And then when we compared to the threshold of 30, which was piloted during the CAST Plus of 2024, the sensitivity even went higher to 97%, with a little drop in specificity. And as such, we had to refer 71% more samples when we use this threshold. So it creates more burden, but of course with an addition, as you can see, we had 101 additional TB patient identified after dropping from 45 to 30. So what do we see from these results? We conclude that CAD for TB version 7 demonstrate very good diagnostic accuracy, actually exceeding the WHO targets. But while Uganda's current threshold of 50 maintains specificity and sensitivity, and we see that a locally optimized score of 45 offered a modest gain with manageable referrals, unlike the referrals at 30%. And it supports the integration of CAD for TB in the national screening program, but with context-specific threshold adjustment to maximize case finding. As part of the implications, we propose revising. We see that revising the current threshold would capture additional TB cases without overwhelming diagnostic services, and adopting an optimized threshold reduces unnecessary referrals, improving cost effectiveness, and also reducing the laboratory workload. Across regions also, we see that it is important to monitor our data to identify optimal thresholds, and also across patient population groups. And this was retrospective, and it relied majorly on existing program data, among others. Thank you very much.
Thank you very much, Chen, for that good presentation. All the presenters are very compliant with time, so we don't have to worry. So next is Diana Cherotin, making a presentation on tuberculosis data quality improvement, ECBSS implementation in 155 health facilities in Uganda. So, Madam Diana, you have the floor.
Wow, good afternoon, everyone. It's a pleasure to be here today to share how our simple quality improvement strategies have helped transform surveillance for TB by improving access to real-time data in ECBSS, making data timely, decisions faster, and our efforts more impactful, even in the low resource limited settings. Gentlemen and ladies, my name is Diana Cherotin. I'm the M&E specialist working with the local partner health services Eastern. That is the activity implemented by Bela Foundation Uganda. For today, I'll be sharing with you how we managed to have our teams access real-time data in Eastern Uganda. By then, we had 155 facilities. So in 2020, as my presenter Mebo had already done, Ministry of Health launched the ECBSS case-based surveillance system that is to capture patient-level data for TB patients. But by then, imagine from 2020, by the end of 2023, that is December, it was scaled up to 155 health facilities in our region, that is the Eastern region containing Bukedi and Bugisu. And we only had 23% that had submitted their data into ECBSS. And by real time, we are saying that when you notify a patient, we want that patient to be entered into the ECBSS. But so far, we were struggling. So on that map, you're seeing how the region was red, and we only had Tororo, which was performing well in having data entered on real time into ECBSS. We all know that without complete data, we cannot be able to make timely decisions, but also it becomes a challenge to us, and we can make wrong decisions as a result of having little or no data in the system. So we were still relying on traditional hard copy data, and so we had to do something to ensure that we get into digitization. So what did we do? We launched a quality improvement strategy, a project which was to initiate and improve real-time reporting from 23% to at least 90%. And we wanted to achieve this in only a few weeks, and we actually looked at having that done within 3 months of the year. And by July 2024, we wanted to see that objective already. What did we do? We conducted root cause analysis in January 2024, and we identified 4 key gaps, and that was undefined roles for the data teams. And then we also noted that there was no data triangulation at the facility, so this became hard for the district teams. You know, we would reach the facilities, they would tell us they have entered all the data into ECBSS, but they weren't doing this data triangulations with existing reports like HMIS 033B, the monthly reports 105, and also the quarterly reports. And then we also found out that our facilities, most of them did not have dedicated internet. So this meant that they would not be able to enter this data into the electronic case-based surveillance system on time. That became a challenge. By the time the electronic case-based surveillance was launched, I think there was no clear direction to have all the backlog cleared. So by backlog, we mean that the TB cases that have been notified from 2020 to 2023 by then. So the districts were still grappling with that. They didn't have this data entered into the system. So when we would tell them that we need your data in the ECBSS system on real time, they told us that, but we do have backlog entries to make. We are prioritizing backlog entries, and later we will come back for the TB cases that have been notified during the quarter or during the month. So that became a challenge for us. So what did we do after doing that RCA? First of all, we we revised and defined the roles of our data team. We had already trained the data teams, and that included one person at the facility who was handling data, but we also trained one person from the programs team who was handling TB data. We ensured that these substantive staff of the health facilities, because I think as the TB program in the East, we had already maybe foreseeing the Trump effect coming. So we didn't want to train only the IP staff on this. So we revised and defined the roles of the data team. Then for the issue of the internet, we provided each facility with only 7.5 GB of data. So we asked them to identify one health worker, and they were able to get at least 7.5 GB of data. I know if you're Ugandan, you know how much that costs. It's not much money. And then we developed a phone directory where we had all the contacts, especially WhatsApp contacts for our health workers, where we would discuss the progress on ECBSS real-time entries. Then after that, we started having weekly reminders to the teams. We were using SMS, using WhatsApp, and also using the email briefers at the time. For sustainability purposes, we realized that we as the IPs, key IPs, will not be able to follow up, on these real-time entries. So we asked the districts to at least identify 2 staff that could be named as ECBSS mentors. So we did train this, we oriented them and trained them. So every other week, every other day, they will be providing real-time support to the health facilities, and it was mainly virtual support. And if it's mandated, then they will do targeted support to health facilities to ensure that they're using the ECBSS system and entering data on real time. And then lastly, I had talked about backlog entries. So we also facilitated a number of health workers so that they would be able to complete their backlog entries. So when they did that, they were able to focus on real-time entries for the TB cases that have been notified. Whoa, I don't know why my graph is looking like that. My apologies. I think this is an issue with the team. We needed to change it to a PDF. Sorry for that, but it was a very beautiful graph. Just to show you, I think if the team behind there can change it to a PDF, it would look much better. But to just show you how we implemented the QI initiative, it was more of a PDSA, plan, do, study, and act. But in the middle there, we are seeing something red like ECBSS downtime. The system, we've been grappling with it, and I know NTLP, you're aware of that. When we're going towards digitization and digitalization, I think that is one of the major big challenges. Do we have enough human resource to ensure that these systems are fully functional, and we do not get to delay our efforts towards digitization and digitalization? So by June 2024, 96% of our TB cases were notified on real time. So by real time, we meant that when they were notified today, they were actually entered into the ECBSS system that same day. Our conclusions. So in resource-limited settings, we did realize that QI methodologies, when integrated into programs, can serve as a strategic entry point for digitization and digitalization. I think we can carry it into the other programs like EAFIA, and also we do conclude that QI supports the adoption of digital tools that enhance efficiency and data accuracy, all while keeping operational costs manageable in limited resource settings. So thank you so much. That is a story from Eastern Uganda.
Thank you, Diana. Ladies and gentlemen, we have listened to four very nice presentations. We started with Madame Mebo Nakawoya, who presented on strengthening TB care through digitalization, the national scale-up of Uganda's electronic TB tracker. Then we'll listen to Mr. Dr. Ignatius Senteza, who presented on maximizing impact with limited resources using the GIS guided TB screening in Kampala, Mukono, and Wakiso districts. We also listened to Louis Ochen presenting on card for TB, threshold 45 optimizes TB screening in West Nile. And lastly, we have just listened to Diana, who presented on tuberculosis data quality improvement in ECBSS implementation in 155 facilities in Uganda. So I want us to pause here and get some comments, questions, before we proceed to the next round of presentations. Thank you very much. So we put up your hand and I will pick you, or I will not pick you, but most likely I will pick you and make your comment or question. And please mention your name and where you work and direct the question to the particular presenter. The question should be brief, to the point. So by show of hand, I want to start taking questions. Yes? Who has the microphone? So one, any other person in that, on that side?
Yeah, thank you very much.
Who is that? Okay, please go ahead.
Yeah, thank you very much, the presenters. My name is Lamu, Edet from Tororo. I have listened to the presentations from all the 4 presenters. The first issue goes to Mebo. Very good work done. The experience you have shared was great. Now my concern is the 12% of the DSTB clients who are not yet in the system. You also highlighted challenges, and one of the key challenges you highlighted were internet gaps. My issue is, with those places that don't have internet, what plan is there to make sure that those patients are captured? And then the second question goes to Diana. Your map looked very nice, and you said it was only Tororo that was doing well. I just wanted to hear some of the lessons you learned from Tororo that drove your intent to make sure that those good efforts are cascaded to other regions of the country for improvement. Thank you.
Thank you. Yes, Madam.
All right, thank you, all the presenters. My name is Ati Miriam. I work with IRC Yumbe. I'm a data personnel. A question I have goes to Diana. I want to know how would we detect and correct errors or duplicated entities into the system. Thank you so much.
Okay. Your neighbor. Don't worry, I'm going to balance the boat. So yeah,
Thank you.
You're going like that.
Matthias from Namaingo. Mine goes to my friend for card for TB. First of all, we are in a situation of working on policy shift to see how we can progressively improve in this area. And what you have highlighted clearly confirm to the effect that we need to go that way. I want to know whether in your introduction of data, you were able to also establish how other factors, other parameters like age-specific analysis and sex, and whether this could have some indication that would require us to readjust our implementation mode. Because I am aware that when you are presenting here, we normally summarize the summaries. So you could have left out things that could have probably motivated me more. Thank you.
Thank you.
Thank you so much.
Who is that now?
I am the one, Dr. Rizzi.
Okay.
I am Kamara Daniel. I'm a nutritionist. My question goes to Meb again. She has talked about digitalization of TB, and I'd like to hear about, are there nutrition indicators in your system that you've put? For example, the mid-upper arm circumference, the weight, the height, the BMI, because they are very essential to help the nutrition teams to detect malnutrition in the wrong reporting system. Thank you so much.
Good. So we have now crossed to at the back. Commissioner, I'm seeing your hand.
Thank you very much, Edward Bitarakwate. My question goes to Dina and Diana. ECBSS was one of the earliest successes in digital health. What advocacy should we do to make sure it's adopted as a standard practice, especially now that we're moving towards a unified digital register and all those other efforts? What else is remaining that we need to do to make sure it's fully adopted?
Thank you. Yes, your neighbor there.
Yes, I think I'm also heading to Diana. I follow PCBSS. You mentor people, they make the entries, then as you go back, you find where you ended is where things are at. So I don't know, what are you doing for sustainability of your interventions to see that at least every month you get to the system to compare what is in DHIS2 is almost similar to what you have in the what? In the ECBSS. What new thing are you putting there? Then I saw you providing 7.5 GBs of data. Was it per month? So how can we sustain these interventions without, how can we sustain these interventions even without this data? Because 7.5 can maybe be obtained from PHC fund somewhere. How can we create sustainability?
So the issue is sustainability. I think the question is well taken. Can move to the next.
Thank you, the presenters. My one goes to the one who is doing GIS screening. Mainja Harriet is my name. I wondered how you go to those GIS hotspots, despite the fact that you're using the phones. Because now in the urban center, you concentrated mainly in the Kampala, but there are lots of refugees or asylum seekers who are staying in Kampala. Were you able to locate, because I could see just like on your map, just the hotspots, but were you able to locate that these are mainly refugees from different countries? And the other one goes to the one who was doing CAS-TB, 30s, the range of 30 to 50%. I was wondering, have you managed, because you are in West Nile, but have you gone to more of the facilities that are on the borders? Because we get a lot of TB cases from DRC.
All right, next. I want to say 1, 2, 3, Sayum, then lastly with the commission.
All right, thank you, Dr. Luze. My question goes to Louis from West Nile. So you mentioned that about 1,000 cases that didn't have documented expert results were eliminated from the study. Do you think that affected your sensitivity, if at all? But also, since you make a recommendation that we spread this across the country, do you think that it's the same picture in low TB burden areas, unlike West Nile today? Thank you.
Next.
Thank you. Edward from Jinja. Mine goes to Mabel. As we celebrate the success story of digitalizing TB data, on the agenda of integration, the center has ably guided that we are moving to integrated digital HMIS. Literally meaning that at this point in time,
the center should be thinking of how the ECBSS digital system should be incorporating other elements, you know, it being integrated with HIV and all these. For example, say the clients we are seeing in the chronic care clinics. What steps has the center taken in ensuring that we digitalize the integrated HMIS? The other is our colleague who presented on briefly the GIS. To me, you highlight it is cost effective, but I think we need to think of a cost benefit kind of study to appreciate whether where we are using those digital, because it required smartphones and stuff like that. So I feel there is a cost implied. So I think we need to be thinking of a cost benefit kind of analysis study to appreciate the cost.
All right, can you please bring the microphone to the gentleman right here? He's right there.
Thank you very much. My question goes to Luis on CAD for TB cutoff point of 45. Quickly, if you can also look at other cutoff point beyond 45, like for example 40, because we have seen recommendation looking at sensitivity and specificity with cut point of 40, and then yours is now 45. I think it would be good to reconcile. So I recommend you follow up with Dr. Aldo at the TB program. I don't know if you are looking at the same data or different data, so that the program has consistent recommendation for follow-up action. Over.
Thank you, Dr. Seyum. And lastly, we have the Commissioner, Dr. Stavia.
Thank you, Chair, and thank you, our presenters. I'll start with the card for TB. When you compare the 30 and the 45, because between 50 and the 45, there was one additional case, and between 30 and 45, there was also another one additional case. And given the advantage in the sensitivity between 30 and 45, do you think this one additional case has advantage in identifying more patients if implemented at a wider scale? Yes, you said many more samples had to be referred, but we also know that for us to identify any case of TB, we have to test many people. So from that, I see the number to screen is 2. Is it for all the different thresholds or for a particular threshold? That one I think didn't come out clearly. Then the GIS mapping team, you say what someone needs is a smartphone. I know in Kampala, I'm not sure about Wakiso and Mukono, we have the ICHIS running where the VHTs have been enabled with the now the word has, it's not a, I think it's a smartphone, tablet or smartphone. How did you work with this team? In other words, who was this person who was using the font to correct the GIS maps? Then for Mabel on ECBSS, I know now with the integration, people are looking at ECBSS to facilitate the development of the integrated disease data system. But as we do that, how have we used this data to engage beyond the health sector as we map hotspots? And I think also for the GIS person, that applies. Have we made any effort to use the hotspots that we map to engage other actors that can help in the TB response? Thank you.
Thank you very much for those good questions. My presenters, I think you heard the questions coming from the floor. I actually lost count of the questions, but I'm sure that all of you picked the questions that are directed to you. And once the questions are that many, it means you have either made them understand or the other way round. So I want to give you time to respond. And this time I want to start with Madam Diana, and we'll come along that way. So you can actually use the microphone next to you and respond.
Oh, thank you so much for these many questions. I will start with the first question. Why was Tororo doing well in the map? Like I said before, Tororo was a pilot district, and all the facilities were trained on ECBSS before rolling out to the other facilities. So the 27, actually about 20 sites in Tororo were already trained by the end of 2023. So they already had ECBSS, and the TB focal persons were very proactive from Tororo district. And that is one of the best practices that we also picked up and scaled up to the whole region. The second question was from the madam. My apologies, I didn't get your name. How do we detect duplicates or remove duplicates from ECBSS? The good thing I'm here with Mabel, normally call her Mama ECBSS. So the system is able to flag a possible duplicate when you are just starting the entry. You know, when to realize that it's almost the same name, then it's able to flag to you that this could be a duplicate, and it's up to you to get other unique identifiers, like maybe the unit TB number, maybe you check the name, the age and sex to see whether this is actually a duplicate. But we have a challenge because we are a number of health workers that are doing entry into ECBSS. The way I write Diana may not be the way the next person writes Diana. Someone will add an H to the end, but for me I might end at an A. So we also ask that when you are documenting in your registers, please, you should be able to write the exact names of the patient, but also how you write your unit TB numbers should be uniform. That way, you'll be able to identify the duplicates and remove them from the system without deleting other patients. The third question, yes, I think they said, what advocacy should we do? ECBSS is already doing well. I think I had a number of questions, like 6 questions. What advocacy should we do? Yes, we do agree ECBSS is working well, but like I said again, local solutions, local problems. We involved the districts actively on this, and we also made sure that we trained the substantive health workers. If we train one IP supported staff, we are training more to substantive health workers. That way they are able to own up the system. So what advocacy, we should use QI again as a region or as a facility. I think it's good for us to list a number of initiatives like the ones we implemented in the East already, and then we study them and we do adopt or adapt to those that are working. And then for what are we doing every week? We have district mentors. So as an IP, we've actually taken a back seat. We just provide technical assistance to our teams, but the teams are able to triangulate data between the three systems, 33B, 105, ECBSS, because we have provided them the technical assistance. We've trained all our DTLSs in the region. They're able to go into ECBSS, download data, they're able to go into DHIS2, so they can triangulate this data. They are trained and they can be able to use the laptops that we provided them. How are we ensuring sustainability of this? The stop work order challenged us, and we actually thought that ECBSS was going to go down because at that point we had stopped providing the data bundles. But so far, we had already started the discussions with the district health teams, and some DHOs had ordered their facility intelligence to include this cost into their PHCs, and they did that. So we are actually very happy that they did that, and during the stop work order, and where we were not providing this so much funding, actually, the ECBSS system was functional and real-time entries were being done. And then, yes, we already have trained health workers. So if we train the substantive health workers, even if the IP left, we believe that the system will still continue to run. So thank you very much, and over to you, Chair.
Thank you, Diana. Luis?
Thank you very much. I'll start from Matthias, who asked about establishing how other factors affect the CAD score, including age, sex, and the other demographics. It's true from previous studies and even from our current analysis, we are noting some differences in the score. For example, we see a difference among male and even the age groups. But for today, we were sharing specifically to look at generally the cutoff score, which would work best for West Nile on average. And then I got another question about whether we have moved to facilities at the border points, and the answer is yes. By 2020, as we were initiating this project, actually the screening was to target West Nile and specifically the refugee population. So these two mobile digital X-rays have been moving across the facilities in West Nile, those stationed in Arua Regional Referral and Maracha Hospital, but they served the entire area. 1,000 patient records were dropped. Could that have affected the results? At the beginning, data capture was a little challenging, more so digital data capture, and we see that we missed some TB patients, or some patient records not captured, including the gene expert, the results could not be captured right there. So it's true, it could have affected our results, but preliminary findings still guide us from about 5,000 we looked at. It gives us a picture which is also in consistency with what other countries are finding out, that the scores may be similar in some settings, and also in other settings we may have different scores. Dr. Seyum asked about the threshold of 40 being looked at national level. Here we had only looked at the locally available data for West Nile for the 2 digital X-rays. I believe if we may be at the national level, it could now be a different average, but this was localized specifically for West Nile, and I'll be glad to share with Dr. Aldo and the Delft team, who have been very supportive in this. Then Dr. Stavia asked about one additional case at 45, one additional case at 30, And does it have any advantage if we are to implement at scale? Additional case at 45 does not go with an exception, a high number of referrals. But when we drop to 30, we see that the number we have to refer moves to 71% additional. And specifically in West Nile, during these campaigns, we have been overwhelmed with samples to the extent that sometimes some even go, they get discarded. So we are trying to balance between efficiency and then also effectiveness. If we drop to 30, we may now be, with the limitations of the resources, we may be challenged further. I think basically those were the ones that shared to me. Thank you very much for the questions. It means you are really following. I appreciate it.
Thank you, Lois, for responding. Mebo?
Thank you so much for the questions. The first question was the 12% not in the system. What's the plan? Some of this data comes from 2020, 2021, and when we checked with the health facilities, some of them, the registers are torn for those years, explains much why we have to move from paper-based to electronic. But the other thing is we have a mobile app for the system, which doesn't use data. It's an offline mode, and the data can be entered in that offline mobile app without internet. So we encourage the health facilities to use that app, especially those that have network interconnectivity. But then also we shall continue to do the weekly meetings to engage the healthy facilities. Case in point, we had the Kayunga region around April this year that had about 30% of the data entered. And with the weekly meetings they started from that time till now, they have all their data entered. So it's a continuous engagement with the health facility teams and the DHTs to be able to make sure that data is entered, the backlog, but then also to continue with the real time. For nutrition indicators, yes, we have them. We have weight, we have height, we have the mark, and we've also added more nutrition indicators in our HMIS revised version. About the question of what else is remaining now that the ECBSS has worked well, I think the next thing is interoperability with the existing systems, integrating ECBSS with DHIS2 so that the health worker doesn't need to compile the report at the end of the quarter. The data is just pushed to DHIS2 for them to have their full HMIS reports. And then also with the EAFIA to have our screened and presumed cases entered there, they diagnosed, and then those that are confirmed with TB are sent in ECBSS to be monitored. Steps to digitalize the HMIS register, I think this is likely to DHI, but for ECBSS, our suggestion is since the ECBSS is up and running, we should have the ECBSS integrated in the currently integrated HMIS register that is being developed. Yes, how have we used this data to engage beyond the health facilities? We've used the data in our WHO reporting. Previously, the age categories we had in our HMIS report, the old report, were not tallying with the requirements of WHO. So we've been able to use that data to do our WHO reporting, the ECBS data. Then we've also used the data to improve linkage of the RR patients to the MDR initiation centers, and that has improved a lot. Like we said, all the MDR cases are in ECBSS, and the linkage has been improved largely because of ECBSS. Thank you. I had so many questions, but I think I've tried to answer all of them. And thank you, Diana, for answering some of these.
Thank you so much. I have 4 questions. One was whether we're able to identify patient level data like refugees. Yeah, when it comes to this, in this activity, we mainly picked GIS coordinates, and the patient TB number was used as the only identifier. We didn't pick other patient level information. However, this information can be triangulated back to the patient records, since our identifier during this is the unit TB number. But also with the introduction of Epicon that identifies information beyond picking the GIS coordinate, I think some of this information like refugee status, socioeconomic status, among others, can be picked. And I think that's why we are seeing so many Epicon guided hotspots these days coming. The second question came from some gentleman, I'm forgetting the name, sorry. Cost benefit study to further talk about the efficiency of GIS guided screening. Yes, indeed, this one is necessary. However, we come from the angle of using minimal resources, fewer community health workers, few gene expert cartridges, when it comes to GIS guided screening versus non-community screening. The third one came from the commissioner who collects the coordinates. So for that period, we used a mixture of stakeholders, including VHTs, linkage facilitators, health workers, among others. However, our next step is to see that when the CHUs have been trained, since they are going to be doing other community activities, we hope to integrate them in identifying these, picking these coordinates going forward. And lastly, how have we used this information? We have, after identifying the TB hotspots and cold spots, we have strategically engaged CSOs to help in areas that are having a lot of tuberculosis. We have also engaged survivors. For example, we're having TB survivors from the Somali community around Chisenyi, which community was a little bit difficult to penetrate. We have got survivors from the tax parks and so on. We have also been able to identify spaces to screen for tuberculosis in the business community, and we think we shall continue to use this information to further improve TB case finding. Thank you.
Thank you so much. The panelists, please join me and give them a warm. Okay. As we've taken the photo with this first set, I want Alfred Otom to come and present on optimizing care for DRTB household contacts. Alfred, is he around? Oh, okay, you are coming. So, yes, can we?
Yes, thank you, panelists. And I want to come back to how we have used the data to engage other stakeholders. You know, we want to end TB. We will not end it by only getting the cases. They will continue to come if we don't stop them from coming. So what I was asking for, how is this data helping us to engage for example, the owners of structure? If I use Kampala, what are the drivers? Who is appreciating where TB is in Kampala, and how can they help us to improve the situation? There are issues of children, there are issues of, so we need to engage people beyond the health team. I was looking at getting those multi-sectoral issues that this data is leading us to. When we look at the ECBSS data, who is affected? Where are they? Why are they affected? And engaging those people so that together we come up with things that can help us to stop the TB from happening in those communities.
Thank you so much, Commissioner, for that additional clarification on how we use the data for CBSS and how it can help us to our journey towards ending tuberculosis by 2030. So we have two more presentations, ladies and gentlemen, and here with me is Alfred, who is going to present on optimizing care for their TB household contacts, findings from Karamoja. Please, go ahead. You have 8 minutes.
Thank you very much, Dr. Ruze. Good afternoon or good evening, everybody. As I've been introduced, I'm Tom Alfred. I work with local health partner services, the TB and urban health activity. I am based in Moroto and covering the whole of Karamoja region as monitoring, evaluation, and learning coordinator. We did this work together as a team, as you'll see in the list of authors. And this is just a preamble, a Karamoja context. It is in the northeast part of Uganda. We are mainly nomadics, nomadic pastoralists. We have marginalized groups like the Ik and the Tepeth that are hosted up in the mountain. We have also high prevalence of hunger, malnutrition, and we have insecurity in some parts of the region that is generated by cattle rustling. So these factors could be the reason as to why we have about 420 cases per 100,000 population. We also have unique practices like that I will not mention. I will maybe cover it during a discussion. So additional background is that Karamoja of recent has emerged as one of the region with the highest prevalence of TB. I am using data of July 2024 to June 2025, and we see that Karamoja matches with Busoga, Kampala, and South Buganda. And you can see on the right-hand side, the graph for the last 5 or so quarters, we are going up. And this is, I think, worth thinking about MDR in the region. But I am presenting a subgroup of these people. We all know that Ministry of Health has an algorithm or guidance that for TB or MDR contacts, regardless of the symptoms or radiographic presentations, they should go straight away to a gene expert test. So as a team, we explored the correlation or the relationship between the resistance profiles of the index MDR TB patients and their TB diagnosed contacts. So we aimed to answer 2 objectives. This is as a result of looking for literature in Uganda. At the time when we wrote this paper, this abstract, we realized that it's only Dr. Seyum, Ebonkolo, and a few colleagues that wrote a paper in 2020 about proportion of TB among TB contacts. And so this leaves out proportion of TB among DRTB household contacts. And specifically, the statistic was found to be between 2% to 5%. In fact, 5.3%. But we don't know yet the Karamoja context. So, but also the other objective was to see what is the relationship between the resistance patterns of the index patients and the contacts that TB diagnosed. We did this work with support from USAID between October 2023 and March 2024. You can see that this is a 6 months cohort. These were patients who were all active on care at that time. So what we did, we found that there were 88 DRTB at that time accessing treatment from 2 gene expert sites in the region, Matany and the referral hospital. We profiled 4,975 household contacts. Of course, what is not brought out in this statement that it was extended TB contact tracing among this DRTB. And again, this is because of the uniqueness of the region. In our region, we do not have boundaries. Today, I can actually start at 4 p.m. like now, start a journey to Nabilatuk. And maybe by 10 p.m., I will be in Nabilatuk. I will stay there, see my wife, see my children, proceed to Amdat, do some raiding, and then come back with a loot, back to maybe Moroto or Kotido. I'm not saying this is happening, but I'm giving an example as to why we conducted extended contact tracing. But also you see the households. This is a typical Manyata that I'm displaying. Who would be your household contact in that case? So some of the things that we did was we used health workers this time around, and we opted for health workers because we know that under resource limitation, we tend to jolt. We tend to play around with who goes to the community. Sometimes we've seen some situations where we say, can't we use the VHTs of that village to do contact tracing? Then we give them some transport refund to bring the samples and the results and so on. But this one, we used health workers typically in order to control the results. We provided them with sample carrying containers as packaging materials. And then also we distributed health workers. What is not here in the second picture is we provided some facilitation in terms of transport refund based on public transport, and then SDA for the day contact traced a particular number of contacts. Of course, the samples were integrated into the normal hub system, and those that were RR cases, we had their samples collected. First of all, these RR cases were picked and sent to the DRR initiation sites. They were started on treatment. Then the rest of the samples were sent to National Reference Lab for phenotypic tests. We found that 44 household contacts were diagnosed with TB. Again, this is a bit higher than what I mentioned earlier, that Dr. Seyum and the team identified a maximum of 5%, 5.3% in the urban areas. So in Karamoja, it's a bit high because this is about 48%. If you do 44 divided by 88, somebody help me with the statistics. But 5 of the index patients had the polyresistant, and then 39 of these diagnosed DRTB contacts were multi-drug resistant. I will not define multi-drug resistance. Maybe it will come during. But the resistance profiles were then matched with those of the index patients, and we found that 23 of these patients had a resistance pattern that was less than that of the index patients. You can see the big white oval, if you can see. Those are the ones that had less resistance patterns. 2, 3 that were polyresistance. For polyresistant index patients, they ended up being DSTB with no resistance, while 18 of the MDR index patients also were diagnosed with the drug-susceptible TB. It's only the small cycle, the small oval circle, where we have a difference. It's 2 patients that provided us with higher resistance compared to the index patients. What does this mean? It actually affirms our algorithm as Minister of Health. And so, as stakeholders in the TB management to end by 2020, probably we need to see how to affirm this algorithm by saying that we need additional research to ensure that we reduce turnaround time of the phenotypic results, because then that helps us to put DRTB patients on the right regimen, maybe comparable or less than what their index patients are receiving. Of course, you know that this will go a long way in reducing toxicity. Thank you very much for listening to me. We did this work with development partners, but above all, allow me to mention the health workers and the communities that allowed us to penetrate these communities, work together with the health workers, collect the samples, and the hubs that did the testing and the referral of the samples. Thank you very much.
Thank you so much, Alfred, on the dot of time. So right now, let me call the last presenter who is going to talk about transforming their TB care, the success of a fully ambulatory model during TB outbreak in Namisindwa, and none other than Damali. 8 minutes. If you can be very short, it's okay. Does that one okay when you try?
Yes, good afternoon, ladies and gentlemen. I'm Damali Waiswa, and I'm representing Clark Joshua. And I feel I'm better positioned to present this work because I'm the regional TB focal person for Bugisu and Bukedi. And I'm here to share that there is need to transform drug-resistant tuberculosis care. So I'm sharing our success on a fully ambulatory model when it comes to patient care. As a way of background,
Press the one in the middle. The one in the middle.
this,
Yes, that one, move it. Can, yes, correct.
then behind.
Move back.
Yes. Yeah, thank you so much. Yes. Just to give you a small background about this very successful story. As a country, when it comes to the treatment model for drug-resistant tuberculosis, we appreciate our traditional model, which has been a mixed model till a couple of months back. Once a patient is identified or confirmed to be having drug-resistant tuberculosis, the entry point is usually through the designated treatment initiation facilities. These are the tertiary hospitals, usually a regional referral hospital or an equivalent of a district hospital. And at that point in time, a lot is done at the treatment initiation facility where workups are done, patient preparations are done, and once the patient is initiated on treatment, then there is room for this patient to be stabilized and is then attached to the nearest facility that we've been referring to as the follow-up facility, which in this particular story we are referring to as the local health facility, where the patient continues with the treatment as well as monitoring by the teams that are there. Now, the story I'm sharing is what befell one of our districts, that is Namisinda district, when one dark afternoon, that was 18th November 2022, that we suffered a surge in the DRTB patient identification, which we refer to as more or less an outbreak. So this followed the community screening in one of the town councils of Namisindwa district, that is Bumbo Town Council, where out of the 32 samples that were tested that afternoon, revealing 14 confirmed RR-TB patients. Of course, as a country, we had to notify There's a slide that I want to bring out. Yes, we definitely notified Ministry of Health, and this was flagged as an emergency response. And one of our biggest challenges of the time was, one, movement of those patients to the treatment initiation facility, that is Mbale Regional Referral Hospital. I think you can see on the map where Mbale Regional Referral Hospital is located, vis-a-vis where the patients were identified in the Bumbo Town Council. Now, the other challenge was the likelihood, given the porous border at Bumbo, that these patients were bound to probably move across the country. So the other area was the likelihood for these patients to drop out before we had them put to care. So we took off time to share with you the outcomes of these patients that were treated, because the treatment model we preferred was moving all what was required to Bumbo Health Center 3. And in the movement, one, we needed to train the health care workers there. We needed to carry the logistics that were required. We needed to engage our counterparts across the country that was in Kenya, and engaging the community for them to appreciate the treatment model. Now, I'm here this afternoon to share or to compare the outcomes of these patients that were treated at Bumbo Health Center 3, a fully ambulatory model, compared with those patients that were identified at the same time but managed at the Mbale Regional Referral Hospital. That was our traditional mixed model. Very important to take note, definitely we may not be able to share all the results therein. We appreciate that we registered a treatment outcome, a TSR, treatment success rate of 95% for those patients that were managed at that facility, as compared to the 88% of those that were managed at the Mbale Regional Referral Hospital. Yes, we get this TSR as comparable, but then we'll appreciate in our conclusion. Yes, in the same cohort where, of course, we note 86% of them were on the 9 months modified short treatment regimen, and all of them were accorded directly observed treatment. When you compare with the tertiary site, that is the Regional Referral Hospital, we see a 4% loss to follow-up and a 4% mortality. Yes, key to note is that these results are comparable, but one of the things we want to emphasize in our conclusion is that this approach actually supports our country's DRTB decentralization strategy, and it further demonstrates the potential of the community-based care models to improve the treatment outcomes nationally. A lot of implications there. The need for strengthening integration for cross-border issues when it comes to TB/HIV programming, and more so as we engage the integration agenda. The development of the targeted interventions for the risk populations. These are cross-border populations, very mobile populations, through the point of entry, TB screening, geospatial mapping to track and we serve these populations. And also following the success at the Bumbo pilot, of course, we see several DRTB treatment sites that have been operationalized currently within the region. And this model, we believe, is scalable. And as we look at this resilient approach of expanding DRTB services, even to other high burden, low resource contexts, especially in the integrated mode. So we further appreciate that
there is need for continued investment in the training, in the data systems, and also in the logistics if this is to be a success. I want to appreciate the teams that are on the screen, and may I say thank you for listening to me.
Thank you so much, Damal. Thank you so much, Alfred, for the presentations. We have run out of time, but to be very fair, I want one question from this side, maybe another question or comment from this side. Just two questions. I see many hands, but just two questions. We are already over, we have overshot. So I want to say, it has to be Sulian and Sayum, and then we can interact with the presenters thereafter.
Thank you very much, Damali. I'll be very quick. Yes, it is true that patients who are stable can actually be managed ambulatory, and you have confirmed this. Are there any patients who at all needed any admission of those 14 at any one point for anything, whether side effects or poor adherence or any other, did they ever need admission? Thank you.
Good. Dr. Sayum.
Thank you very much to both of you, really very impressive presentations. I'll make it short and go directly to Alfred. Really, your presentation shows your in-depth understanding of the local context and how you used that to apply to case finding, in this case for DRTB case finding. When I did the maths, for every index, you followed up like 56 contact, which is way, way beyond the usual index to contact ratio, maybe 1:8 or 1:7. So what does that mean, just in terms of program level implementation? How is it difficult to implement that kind of context-based index case finding, maybe in other region or other context?
Thank you so much. And some brief responses, Damal?
Yeah, thank you so much, Dr. Susan. We appreciate that over 90% of these patients were actually stable patients. And one of the patients that needed admission was the one with previous treatment for second line, and the need for a review of her regimen called for this patient to be at the treatment initiation facility, and meaning this patient had previously believed was one of the pockets for the spread that transfer. But I want to share this evening that even when we admitted this patient, she ended up running away and went across the country. The rest of the patients were stable, and I concur with you that yes, they are actually having good treatment outcomes, and none suffered serious side effects to the medicines.
Good. Atom, 1 minute.
Thank you very much, Dr. Sayum. Now, in the Karamoja context, we have mentioned that the team or the inhabitants of Karamoja region are mobile because of their way of life, nomadics. And so for our situation, it would be nice to mobilize maybe 2 days before the real approach at the patient's home to counseling of the patients on the implication of contact tracing, but also the implication of TPT and the rest of the advantages of contact tracing. And then also we need to work together with the LOC, the local government system of the place. They understand these people, and once a Kejong like me is called upon and told by LC1 that be home tomorrow at 8, surely he will be there. Thank you.
Thank you very much, team. I want to put our hands together to appreciate Alfred and Damas. Thank you so much. And also appreciate me. Yeah. So the session is over. You can engage with the presenters, all of them, at any convenience. So my time has come to an end. We can just come and we take a picture with the cameraman. Okay.
As people prepare to language, we have a next session. We are late. It's already 10 minutes past 4 p.m. So I'm kindly requesting that the next group that is coming in here, which is integration of HIV services in chronic care. So integration of health service of HIV services in chronic care, Uganda experience, challenges and opportunities is the next group that is coming in. And I do believe that the chair, Dr. Veni, is in the room. Veni Nabitaka, yes, there she comes. We still have sessions going on if you would want to join. We have one in Shina Hall down, ending malaria death in Uganda, burden and the new interventions, including vaccine. Very interesting. We have another one in Royal Hall, health systems resilience and emergency preparedness and response. And then we have another one that is beyond burnouts, managing workplace stress through evidence-based intervention and relaxation techniques in Mira Hall. So I give this opportunity to Dr. Vic to come in and take on the next session. Thank you.
Thank you, Dr. Raymond. I hope that we still have a little bit of the lunch in somewhere in our veins and no one is hypoglycemic. No one is low on sugar. So good afternoon or good evening. I think we are going to the evening, but let me not discourage everyone. My name is Veni Nabitaka. I work with the Clinton Health Access Initiative as a Senior Program Manager, and I have the pleasure to moderate this next session. We will try and be very brief in this coming session. As Dr. Raymond